Everyone, thanks for coming to the pre-med themed brochure sharing session. I asked you all to turn on your cameras on. It helped improve interactions in the sessions where we've had students have their cameras on. We've had a lot of great conversations, and I think that really helps. But this session will be recorded, so keeping that in mind. We'll send a link to the quiz at the end, toward the end of the session. But thank you all for coming. So today we have Dr. Richard Wender. He's a family medicine physician from University of Pennsylvania, and thank you from there. Thank you. Good to have you, Dr. Wender.
Well, thank you so much. I'm really delighted to be here and join the group. Delighted to see so many of you. I can talk all night. You don't want that to happen, although I love telling stories and all of my things that I've learned through the years and enjoy sharing with others. Hang on just one sec. Sorry about that. But what I would love to do is leave as much time for your thoughts, your questions. You know, my current job is chair of the Department of Family Medicine and Community Health. And 7 years of my career were spent really in a public health job as the Chief Cancer Control Officer for the American Cancer Society, leading that work in this country and around the world. So I'd love to talk about the big pictures of healthcare and how that relates to your futures as physicians for all of you who do opt to keep going down that path. But you know, I was asked to start kind of with my own story and my own journey and how I decided to be a doc and eventually a family physician and kind of where my career went. So let's do that. I was born in Pittsburgh, Pennsylvania. I have lived in Philadelphia for 45 years. People occasionally ask me if I'm still a Pittsburgh Steelers fan. My response is, was I unclear about something? Everyone born in Pittsburgh, Pennsylvania is a lifelong Pittsburgh Steelers fan. So that never changes. But we have lived in Philadelphia for 45 years. And it's interesting, when it's a little dull, I think, but when I was in elementary school, I remember there were a couple of books in our school library that were kind of about healthcare and medicine. And I remember I kept being attracted to those and going back to them. And going through high school, I briefly talked to my dad. I was very involved in my synagogue about being a rabbi. And the only part I didn't love about it was the religious part, which is kind of a big deal to be a rabbi. So, but I love the interaction. I love the human part of it, and ultimately that is what always attracted me to medicine. I didn't really view myself as a scientist in any way. Really, just loved human interaction. Loved the joy of being able to be of service to people or feel like I was doing good. And to this day, there's nothing that gives me greater pleasure. I spent last Saturday volunteering at an incredible vaccine clinic that we put on at Penn. And, as you know, we've really been struggling to achieve equity with delivering the COVID vaccine. And Philadelphia is about 46% Black population, and the vaccine rates have been much higher in the majority white population than in the Black population. So we really worked with tons of community groups, and we delivered in one day at a big clinic 1,830 vaccines, which is incredible. It's the most I've ever heard of for a single site in a day, all run by volunteers. And brilliant logistics, and 75% were people who lived in our community, Black population, and all first dose but you've all done these kinds of things. The sense of joy you get to be a parts of events like that are just so terrific, and that joy never fades. It doesn't matter how long you're doing it. You really, really like it. So that's what attracted me to medicine. Was I just had this sense that it was a service job that would be very satisfying. And I remember, so I went straight through, undergraduate school. I knew I was going to apply to medical school. The only time I made a mistake, I listened to my parents too much. My parents said, well, if you're going to go to medical school, you should major in a science. And I knew I really didn't want to major in a science, but I did anyway. So I majored in biochemistry. Big mistake. I'm not a biochemist. And I remember to this day I went to a school that had a required senior thesis. And I was supposed to be in the lab, and I was so bad in the lab. It was stunningly bad. And I got summoned in halfway through my senior year by the guy who kind of ran the student program for biochemistry, named Levine, who's a very famous guy. Dr. Levine calls me and he goes, I just want you to know you're failing your senior thesis. So I said, oh, good. Well, thanks. But I had a great advisor who said, some people aren't cut out for the lab. Maybe you want to do a library thesis. I go, that's a brilliant idea. I'll do that. So I made it through. But I did all the way through college, had a chance to do lots of literature courses and really valued those. And in a way, it was liberating to not be majoring in English because I got to do all sorts of literature and translation and all that good stuff. But the bottom line is I knew all the time I was going to go to med school, went straight through and got married very young. I married my high school girlfriend. And so we got married I was 21 and we came to Philadelphia where we've been ever since. She went to Penn Law School and I went to Penn Medical School. She taught at Penn Law School in the middle of her career, and she's been back at Penn for 11 years as the research integrity officer. So we're now both back at Penn. So Penn is, particularly back then, I mean, you have to realize I entered medical school in 1975. So family medicine as a discipline was only 12 years old. And Penn was certainly, as a very research-intense institution, wasn't particularly known for its primary care focus or family medicine focus. They had no department of family medicine. Back then, the discipline was called family practice. It's family medicine today. They had no department. And so I kind of thought I wanted to be a pediatrician. And I think what I liked about that concept, I was really modeled after my own pediatrician. I just liked the idea of being someone's doctor, really enjoyed that idea. And that people wouldn't have to know what was wrong with them when they came to see me. It would be my job to figure it out. They would have trust in me. I'd have responsibility for their preventive care. And I didn't consider myself any sort of brilliant med student, but I must admit, I took the first course I had was medicine in my clinical rotations. And I remember doing that rotation and then having some classes with my classmates. And all of a sudden, like I was answering questions and I seemed to understand things which I had never understood before. And I remember a couple of my friends said, what happened to you? And I said, I think I just needed the clinical context. And I've told students that to this day, that you always worry about your knowledge. Are you going to be able to gain enough knowledge? And I've always told students, and particularly residents, nothing will stop you from gaining the knowledge that you need. Doesn't matter how hard you think it will be. You always gain the knowledge that you will need because those important things get repeated over and over and over again. And more importantly, it's amazing how your learning changes when you're reading something in a book or watching online or hearing a lecture until you're responsible for taking care of a patient. And then when you're responsible, all of a sudden, your intense focus on doing the right things for the patient just fuels learning. It happens to everybody, and it certainly happens for me. I still remember a case from my residency, and I remember being completely baffled by learning about the kidney and the hormone renin, and it affects blood pressure, and it affects aldosterone and all this stuff. I thought that was, you could have taught me that a million times. It wouldn't have mattered. But I had a patient, and I suspected that he had something called renovascular hypertension, where poor blood flow to the kidney was causing severe blood pressure elevation, which is very difficult to treat. And the workup for that involves stuff like renin and aldosterone and angiotensin. And it all, I kind of read about it and it all fit. And I remembered it ever since because I had the context of actually providing patient care. And I almost remember the exact moment I became a family physician. Again, you have to remember, I was thinking of being pediatrics. I'm here in Philadelphia. I'm taking all these rotations at Children's Hospital of Philadelphia, the #1 rated pediatric hospital in the world, having these amazing experiences with legendary people. But a classmate of mine who, knew what I liked to do, came up to me one day, and I don't even remember, just kind of spontaneously said, Rich, I was thinking about you. You should go into family practice. And I said, what the hell is family practice? I had never heard of family practice. She said, oh, it's just like being a pediatrician, but you do it for everybody. You do the whole family, the adults and the kids. And that was the moment. I said, that's it. That's what I want to do. I didn't know that existed, but it is what I want to do. And so I made up my mind to do that. And we were in an apartment building in Philly, and our neighbor, who we were very close to, was a pediatric oncology fellow at Children's Hospital, taking care of pediatric cancer patients. And she's a really close friend and, obviously more senior than me. I'm still in med school. And we're talking one day about my going into family med, and she asked me, oh, where did you do your family, again, it was called family practice then. Where did you do your family practice rotation? And I kind of paused and I said, I've never done a family practice rotation. And she kind of very quiet. I go, are you supposed to do a family practice rotation? Says it's pretty common to do a rotation in the discipline you're going into. I said, that kind of makes sense. So I found an elective at Reading Hospital in Reading, Pennsylvania. Did not particularly love it, but it didn't dissuade me. I really had in mind what I wanted, what I would enjoy doing. And I had the advantage of being here in Philadelphia. And although the University of Pennsylvania did not have a residency, did not have a department at the time, right across town at Thomas Jefferson University, they had a well-established department, a great residency program. And I just knew that's where I'd want to go because I kind of had in mind of wanting to do academics, which I'll get to in a moment. So let me just pause there and say a little bit about, how I've advised medical students about career choice. And I realize more and more students come into medical school kind of already have in mind what they want to do as a discipline. I will tell you what that looks like from the faculty's perspective. We always look at it and go, how do they know that they want to be a nephrologist, before they've even come in? But there are good reasons, and a lot of students do exactly what they thought they would want to do. Some certainly change. But when students are struggling, my own feeling is, and I realize there's different opinions about this, to think about how they want to spend their career. The answers are not outside you. They're not about which rotation did you like the best in medical school, or I had this experience, I really like this experience. A rotation in medical school can be a function of whether you had good teachers or not, and whether you were busy or not, or how much responsibility you had. It's not completely trivial, but I don't think that's the best way to determine your future. I think you have to really look inside and say, what do I really enjoy? What feels right for me? What's rewarding for me? And I knew the answer for me. I wanted that interpersonal relationship. It was the relationship that was first and foremost, that trust, that I would be the most trusted source of care for someone. And I always had this idea that it was important that they could come to me, and it was my job to figure out what was wrong from a diagnostic standpoint. And I'll talk about the other part of family medicine, the preventive part, in a moment. And when I was in medical school, the same thing was true if somebody wanted to go into a surgical specialty. I always said, get to know what drives surgeons, what excites them, what are they really jazzed about. And 90% of the time, what you'll hear is they're jazzed about being in the operating room. They love the actual surgery, the fact that they are in there. They can do something that cures somebody from an illness. So don't go into surgery unless you really love that, that it gives you deep enjoyment to be the one who has that skill. So for every specialty, and then for people who do research or who really go into something that depends very deeply on the physiology, something like nephrology, same thing. That's what just gets you. I love the mechanism of disease. I love understanding that. So the more that you can understand your own motivations, the own things that you find really rewarding, the better. Don't get me wrong. Every discipline needs physicians who care deeply about the outcomes of their patients. So it's that match of caring, but also knowing the kinds of skills, the kinds that you want to really bring to bear and that you think you have a special gift to bring to bear. And for me, I knew it early on. It would be something about this relationship, about communication. And the chance to do it for adults and kids was great for me. So let me jump forward a little bit, given that I was choosing between pediatrics and family medicine. Interestingly, more than I ever thought I would, because I was more motivated by the relationship side than the kind of the science medical side. But as I got into residency and beyond, I found myself just absolutely loving the complexity of the medicine. And I love the diagnostic. To this day, I really like the diagnostic challenges. I like understanding the management on how to do my job and learn those skills. And again, once I got in the context of really caring for patients, I actually was able to remember and learn the things I was supposed to learn, which when I was just sitting in a classroom, I could do fine, get through the exams and all that good stuff, but it wasn't really learning. It wasn't really owning the information. And if you want to be a pediatrician, do not let me dissuade you at this moment. What you are about to hear is just me. Pediatrics is a great career of life. Some of my best friends are pediatricians. But I have looked back on it and said, for me, I think I would have made a mistake going into pediatrics. And I'll tell you why. If you do primary care pediatrics and primary care adult medicine, in primary care adult medicine, you diagnose and manage a huge range of conditions. Hypertension, diabetes, diagnosis of cancer, screening for cancer, chronic renal disease, endocrine disease, thyroid disease, and in family medicine, gynecologic illnesses, and on. And I really liked that variety, of managing the illness and the diagnostic variety and challenge. Pediatrics is a little different. Pediatrics, there's things that are normal. You get a lot of those, right? I just saw a baby the other day in the office, and the mom, the baby had a really bad night or two, and the mom felt something was going on in their mouth. And I had to have the confidence to examine that baby and say, what you're seeing is normal. It's just normal, not just normal. Doesn't feel that way when you're freaking out as a mother and your baby is up all night. But that is normal, and here are some strategies to manage it. So normal or normal problem. So ear infections in kids, very common. It's a problem. Recurrent could be a problem, but it's so common. It's within the range of normal experiences for kids. And then the third is kids who are really sick. And to me, the most foundational, fundamental skill that you need in taking care of kids is to differentiate the child who really is ill and has something more seriously wrong. And there's lots of clues to that. The difference is that in kids, you don't get to manage that really ill child. That's a much more rare event, and they're largely managed by specialists. And you'll find in a lot of general pediatricians that over time, they do tend to focus in one area like sleep, disorders, behavioral health, headache, or stuff. that happens in adult family medicine too, where you kind of tend to focus your practice. Bottom line was, family medicine was the right discipline for me. And it gave me everything that I had imagined it would, that foundationally built on the doctor-patient relationship, and earning trust, and being able to do so quickly, right? You don't necessarily get 3 shots at it, right? You're seeing a patient for the first time, someone who may not have had good experiences with the medical system in the past. It's your job to develop the methods to establish trust quickly, so that you can get the information you need, have them trust your recommendations, and have a partnership. I was not completely away from clinical medicine for 7 years, but doing very little clinical medicine, just once a month. Now I'm back to doing more of it, now that I'm back as chair of the department at Penn. And I mainly see people who are sick. They're coming in, they have someone else as their family doc. And for me, that's a good fit. I like the diagnostic challenges, but I also like the opportunity and challenge to earn their trust quickly, even though they've not met me before. So lots more that I can talk. We'll get into my career, but can we stop there and just see what people's reactions, thoughts, questions are? And I think that's a good place, kind of taking a breath spot, and happy to get any of your reactions or thoughts or questions, and then we can kind of move beyond that and talk a little bit more about my life beyond those initial choices.
Yeah, absolutely. I think that's a great idea. So if you all have questions, you can put in the chat, or feel free to unmute and speak up, or you can keep it in the chat. So wait for people to have questions. Let's see.
I'm great with silence. I can do this all night.
Oh, there's a couple of questions rolling in now.
Good.
People didn't need time to type. So,
I wanted immediate. So should I bring up the chat? Would that be?
I can read it out for you.
Okay, go ahead.
Okay, so the first question is, what is some of the best advice you have received?
Yeah, good question. I think the best advice that I ever received was from my wife, when she told me, call the plumber. You said you were going to call oh no, that's not what you meant. The best advice, that's interesting. I always think about the best advice that I give. I don't think about the best advice that I've gotten. I'll give you, this isn't quite advice, but it's something that someone did with me that has really served me. Because the next thing I want to talk about a little bit is leadership, and this kind of gets into leadership. But it was, and I do have one little piece of advice that's brilliant that somebody just gave me recently, and I've incorporated it. It's such a little thing, but it was so cool, and it's worked very well. But this was an experience I had, and it left an impression on me. I tell the story to this day. When I graduated from my residency program and was joining the faculty, the department chair was also the residency director. So for reasons not worth going into, but I kind of took over running the residency literally the day I graduated from the residency one day, and I was running the residency the next day. But he was the official director. So he said, listen, do this for 5 years, and then we'll get through another accreditation, and then we'll transition. You'll become the official director. 2 years in, he walks up to me and he goes, you're now the director of the residency. I said, Dr. Brucker, we had an agreement. You said you're going to do this for 5 years, and then, then I would take over. Why'd you change your mind? And he looks at me, and he was a very quiet guy. He went on to be the president of Thomas Jefferson University, actually. And he looked at me, he says, because you are the director. And that always struck me. I've tried to really live that when someone is doing a job, that then recognize them for doing that job, give them whatever title you have, give them whatever position they deserve, give them the recognition that they need. So it wasn't advice, it was something that was a way that I was treated, but I found it so valuable. And I've tried to do that in my leadership positions, that no matter how young somebody is, if they're doing a job, recognize them for it, give them the title for it. And here's the tiniest little piece of advice. It's not the best advice I've ever received, but it's such a cool little thing, particularly in a big system. And I'm a leader in a big system. And I have an executive coach that I work with that Penn gave me, and we're close and we talk every month. And this was something she learned from a CEO of a business, and she put it into her email habits, so she passed it on to me. So try this out. She says, take the word but, B-U-T. You can take the word B-U-T-T out too, but take the word but, B-U-T. Don't use it in any emails. I go, that's a cool thing. So I started to do this, and it will change your email communication. In fact, even in your spoken communication, try to minimize it. I'll give you a very simple little example. That presentation that you gave was really good, but next time you do it. So you just negated what you said, right? You said it was really good, but next time you do it better. Just take the word but out. That presentation was really good. Next time you do it, why don't you try to add, it changes the meaning. And when you're trying to resolve conflicts, and the higher up you go in leadership, the more sensitive you have to be. You have to be aware that your words really matter. Particularly at this point in my career, I'm an old guy, I've been at this forever. And, I'm a new chair. People really care about what I think. So there you go. It's my little pearl. I don't usually pass on little pearls like that, but I really like that one. Let's do another question.
Yes, we have a lot of questions in now. The next question is, what is one advice you'd give to a student going into medical school?
Yeah, it's hard to leave it to one. But I'll give you the main one. And it's probably in the range of, don't ever freak out while you're in medical school. In a way, I watch people going through med school and going through PhD programs. PhD students occasionally really get in deep trouble. They're working with an advisor, and they come in one day and their advisor, who they've worked for 3 years, says, "Oh, I'm leaving. I'm going to another institution." Med school, once you have been able to get into medical school, and almost everybody can get into medical school if they're persistent enough, they really want to do it. I know how much pressure it is. I know how difficult it is. But I've watched students whose grades or exams, weren't what they wanted them to be, and they've stuck with it, even if it's taken 5, 6, 7 years. And they almost always do it. Perseverance is the best they can. I do think that this becomes an issue a bit of privilege in life. I think if people have economic pressures, which are more common in underrepresented minorities, Black, Hispanic, Latinx population, Native American populations, Alaska Natives, more common, it can happen in anyone. It can be hard to persevere if you have financial pressures that force you into a certain path. So I do recognize that privilege makes perseverance to get into medical school easier. Once you are in medical school, you got this. You got this. Just do your thing. Don't put too much pressure on yourself. The med schools want everybody to succeed. Your advisor isn't going to go to another school. They really want folks to move through the issue. And it's harder to get into medical school than it is to get through it. Don't put too much pressure on yourself to learn everything. I know it seems strange, but when you look back on your 4 years of medical school, you'll barely be able to even remember what they were like. All medical school is kind of getting you ready to then learn your career, which really begins in residency, where we actually give you a paycheck, which is a nice thing. You're actually earning a bit of a living rather than paying us a ridiculous amount of money. So that is my advice, is don't put too much pressure on yourself. You're going to do fine and do well. I think it gets a little tough or tougher for the student who decides, depending a little bit on what discipline they're going into, the future orthopedist who wants to be at a certain residency program where the number of applicants is higher, and then people really do put a lot of pressure on them. And then final point, and this one I cannot emphasize enough, and really it's the most important. Maintain your honesty and integrity through medical school, no matter what. Do not ever be that medical student who says, I need a certain grade. I'm going to go ask for a certain grade, or or do behaviors that you would never dream of doing it just to try to respond. That goes for your whole career. I mean, that never changes. But I see medical students sacrifice that at times because they feel they need to get a certain grade or do a certain thing. So you're going to do fine. You get into medical school, you'll be very successful, but don't ever let it sacrifice your integrity.
What is the work-life balance in family medicine?
It's a great question. I think it's a very serious issue. If you look at burnout by discipline, it is family med, primary care in general internal medicine, primary family meds are close to the top. They're not always the very top, but they're close to the top. And I think it is because of the pressures of being available to your patient, not just while you're seeing them, but now with the electronic medical record, the patients are messaging you, et cetera. We haven't talked about income, and I think it's worth talking about income a bit. And the department I was at Jefferson did a lot of research about the relationship between income and career choice and indebtedness. It's a very complex relationship. Students who go into family medicine, ironically, tend to have higher debt, not lower debt, than students going into more lucrative professions. And I think it has more to do with people's lifestyle goals and expectations. People who come from wealthier backgrounds feel pressure to and the desire and the expectation to duplicate that lifestyle. And so because they came from a wealthier family, they have lower debt, but then they go into higher discipline, reimbursing disciplines. So that it's counterintuitive. Recently, with the really, really super high levels of debt, that does seem to be moving some students out of going into primary care disciplines, which are lower reimbursing. One of the pieces of advice I give to all students when they're making career choice is try not to let debt influence your career choice. You will be able to manage debt, even if it's high level debt. There are methods and ways to manage it. You'll be earning a good living. But you do have to match with recognizing that family physicians, on average, are earning perfectly good living by American standards and an incredible living, but certainly less than some other disciplines. And the real question was about work-life balance. So our discipline is taking this really seriously. We need people to feel comfortable. We want people to have families. I have a very young department right now. Almost all of my residents and faculty have kids. And we, of course, we're in the middle of COVID, and they're balancing all of these incredible pressures. So we're working very, very hard to be responsive and be sensitive to that. I just had a faculty meeting today, and I said to the faculty, I said, we have these incredible opportunities to volunteer on the weekends at our vaccine clinics. Anyone is welcome to volunteer, but don't volunteer if this is important time for your family. That has to be your priority, only for those who are able. So I think, long answer just to say, schools and hospitals are taking balance more and more seriously. And there are ways you can shape your career choices. For example, whether you want to deliver babies or not, and how long you do that can make work-life balance better. The biggest threat to the work-life balance, I find, is the fact that through the EMR, patients, they're always there. They can reach you at, after hours and weekends, et cetera.
The next question is, what does your day-to-day schedule look like?
Well, my day-to-day schedule isn't like a normal schedule. It's because I'm a department chair. I'm like, um, listen, I knew early in my career, just how I knew I kind of wanted to be a doc, and then I knew I wanted to be a family doc. I also knew pretty early in my career I wanted to paint with a broader brush. I love direct patient care, but I also wanted to do things that affected populations, public health, and I've always been in leadership positions from my earliest days. Uh, so at the very, very most, early in my career, I saw patients 4.5 days a week, 4.5 days a week. Now, 4.5 days a week of primary care translates to about 6.5 days a week of care, because you have seeing the patients, you're always running a little, start early and a little late. And then you have phone, back then it was phone calls, now in our responses, it's follow-up care. And so, for example, in my practice, if you're seeing patients 8.5 days a week, we consider that full-time clinical practice. So 8.5 days, it takes you 2.5 days to do all the other work that you need to do. Nobody can see primary care patients 9 or 10.5 days. Very difficult to do that unless you have incredible levels of staff support. And we are trying to work on those models. Patient care, one of the things I've always loved about patient care, no matter what else is going on in my life, when I am in the room with a patient, the world disappears. The world disappears. It's just me and that patient. That's all that matters. That's where it's such a unifocused, intense focus, and the world literally disappears except for what you're doing right at that moment. And so many remarkable, incredible moments through my career, just in the room with patients or on the phone with patients. And then for me, the rest of my life is, probably not too dissimilar to yours. I'm on the freaking, Microsoft Teams and Zoom and, morning to night. And if it weren't for that, I'd be on phone calls or other meetings. Now it's, of course, video platforms. It'll be interesting to see what the world returns to. And I have a pretty amazing balance of lots of local issues and leadership meetings, but I also still am doing my national work and cancer control work, which has been so it's a great deal of diversity. I truly am a family doc. I like the spread. And I'm older, I have one daughter. She's married, old married lady out of the house. So, my wife's working full time. So we both put a lot of hours into work. We've always done that.
Good. The next question is, how do you know when to refer to a specialist versus when to keep the patient under your own care? And has this threshold changed over time during your career?
Yeah. I want to tell one patient story just because it popped into my mind, and I thought it illustrates something about what I love and about our discipline, and kind of the gift that you have as a physician. One of the things that's given me the greatest joy of many is caring for people who are grieving. And that is a common event. One of the most common emotions with grieving is guilt. It's guilt. And you cannot make guilt go away. People have to experience their guilt. But you have this very special position as a trusted physician, as a family physician, more than almost anyone else, more than a psychologist, more than a family member, to acknowledge a person's guilt, realize that they may have to feel it, but actually with the confidence and the authority of being a physician, to provide some objective feedback, to be able to say, everyone feels guilty, but objectively, just from a medical standpoint, there is no reason you should, that you did not alter that, whatever that feedback is. Those are some of the most unique, special moments, to be able to see a burden lift off of a patient's shoulders through your relationship and your caring and your love, and really unique. What the hell was the question? I have no idea. What was the question again? It had nothing to do with that. I know that. But
The question was just about like, how do you know when to keep the patient under
Oh,
your care
yes.
as a specialist?
Who cares? Let me tell you another grieving story. Anyway, hey, listen, you know what I said? You learn the skills that you need to learn. Um, and I'll give you this one, and so you're going to learn it. You don't have to. It's something that we teach and something that we educate. Um, and the most important lesson is that when you're getting your spider sense, when the spider sense is tingling, that you're a little bit out over your skis. Maybe that's a good time to specialize. And I always said, the most scary time in your first year as a resident, in your internship, it is not in July when all the interns are new. Because do you think there's a single intern who wants to say, oh, I got this, no problem, I don't need to ask for help? I mean, my God, you can't believe that they think you're supposed to know anything. So you're asking for help every moment, every moment. The point that always made me a little nervous was halfway through the year, where they said, okay, I got it now. I don't need to. You never have to question about asking for help, asking for another opinion. And but it's actually a great, really important question as a family physician, because the graph of when you ask for help, when you consult, is your graph, and it's unique to you, so that a physician who has a lot of depth of knowledge in maternal child health care and who sees a ton of kids and who does a lot of prenatal care, may deliver babies, their graph for when they refer looks really different from my graph, which is more adult geriatric chronic disease focused. So remember what I said, what's the minimum knowledge? You got to know when someone's really sick, where you need to intervene quickly. I feel confident to do that. But the nice thing is I'm in an academic setting. Sometimes my asking for specialists is just asking a colleague who's right next door. I may not have to go anywhere, but you'll quickly learn that if that little sense is, I'm not sure I got this, you'll figure it out. That's the time where you need to find a good way to ask for help. This isn't a matter of being, your obligation is to make sure that the patient gets the best outcome that they can. It's not to show that you're some sort of megastar, who can handle it all. In fact, you know what the phrase is? We call that being a cowboy. A cowboy is somebody who wants to handle all their stuff themselves. And it's okay within your personal graph to handle some things that some other family physicians might refer, but it has to be within your skill set.
And the next question, kind of like you mentioned a little bit into it, but how is family medicine different in an academic versus a private practice setting?
Yeah, no, that's a really good question, because they can be pretty darn different. They can be relatively close together, but over time they can be pretty far apart. So academic family medicine is no different than any other academic discipline. I have faculty, and we're recruiting faculty right now, both pure PhDs, MD PhDs, MD masters, who will spend 80% of their time chasing grants and getting grants. Now, the topics we study are different. We tend to be studying things like social determinants of health, mental health problems, integrating with primary care, chronic disease management, preventive care. Those are the topics we study. But we have people who are 80% research, and their main job is conducting and publishing. And on the other extreme, we have people who are in academic settings, but almost all of what they're doing is providing clinical care, mentoring residents, and teaching students. So those are all important, critical. The second model is the more common one in family med, where you're maybe seeing your own patients 6 half days a week, precepting residents 2 half days a week. And then usually what happens when you're hired into an academic job like that is that you start out very heavily clinical. And then over time, the med school may say, we need you to teach a course. We'll pay 10% of your salary for you to teach this course. And then you get to reduce your clinical somewhat and teach the course. So a lot of what department chairs have to do is just that. We have to keep looking for opportunities for our faculty to get additional opportunities as they grow. So it's quite a, being academic family medicine, and there's a huge variety from intensely research to pretty intensively educational and teaching and clinical. Yeah.
Okay, I'll glance over some of there's a lot of questions, so I'll glance over the ones that you've already sort of done because there's some similar overlap. The next question is, you said that you have experience with the public health system here in the US. What would you say the biggest challenges you faced in the working in the public health setting? And what are the major differences between the private health system and the public health system?
Well, let me go to the last one. We don't have a public health system versus a private health system. I mean, the provision of healthcare in the United States is integrated, right? You have some people who have their source of their healthcare insurance is a public source, Medicare and Medicaid. And then you have others who have commercial insurance that's usually employer-based or through the Affordable Care Act. But from a consumer, from the physician standpoint, not the consumer, it all feels pretty similar. And the way it's similar goes back to the 50s. And it really was one of the pivotal moments in the history of the economics and healthcare of the United States. And it was really 40s and 50s when employer-based healthcare emerged. And the reason it emerged was it was following World War II. Employers were trying to compete for the soldiers who were coming back from the war. And I don't know who first thought of this idea. They said, we're going to offer health insurance. That's how we're going to compete. It was not an organized decision. Nobody sat down in Washington and thought, that's a good idea. That's how we're going to provide healthcare in this country. It was really the competition. Then in 1963, when Medicare and Medicaid came in, Medicare and Medicaid to this day have some weird rules that basically they were obligated to pay whatever the doctors paid. So when you add it all together, we are the only I think we're the only country in the world that gave the provision of healthcare over to the free market, to market forces. And it's been pretty much it's been a success as an economic driver in the United States. Our number one industry is healthcare. More people are employed in healthcare than in any other part of our society. It's the number one or number two employer in every big city in America. It's pretty resistant to recessions and depressions. People still work in healthcare. But it has led to extraordinary levels of inequity. Because, the fact that we have, what are we up to now? We were up to 46 million uninsured, and now I think we're at about 29 million. So the fact that there's so much money being earned in healthcare, and it's such a big source of income, and we kind of compete around income, and we allow market forces spend way more on healthcare than any country in the world, and yet we have 29 people who are uninsured and many other who are underinsured. So to me, that's just a flat out failure of that's not truly a healthcare system. And it really is going to demand very disruptive change. So if you look at what it means to work in public health, I think that's evolving. I think increasingly we are appreciating that there are root causes. Have you all heard, raise your hand if you've heard of the term social determinants of health? Rachel has. So that's good. Lots of people. Good. Social determinants of health, like food availability, educational achievement, housing, the environment you live in. Those are so-called social determinants of health. But there's a recent book, which I think is very critical, that pointed out the social determinants of health really emerged from policies, from the political determinants of health. And when you look at the roots of that, and I don't mean to be, I hope this isn't viewed as political, it's really historical. Many of those policies emerged motivated by racist attitudes, exclusionary attitudes that, for example, when the New Deal was passed, it was only passed by giving the rights to the states, and some states specifically passed laws and policies that excluded Black population from the benefits of the New Deal. So I think this past year and a half, we've all been studying and learning more about that. So when you're working in public health, you have to be working on multiple levels, looking at those policies. How do we reverse the policies that led to things like economic disparity? What was just passed, the 1.9 million, trillion dollar bill, is one of the biggest anti-poverty actions in our history, and we'll see its effects. Economic disparity, those policies. Then you have to address people who are suffering from social deprivation, food availability, housing availability, the mental health repercussions, and then intervening at the level of the individual to help them if someone needs patient navigation or needs rides to make sure they have those services. So what I'm really interested in trying to devote my career is that continuity between the patient who is experiencing the repercussions of these issues and trying to get more at the root causes. There you have all of American healthcare in 5 minutes.
Have you ever regretted going into family medicine?
Oh, what do you all think? Do I look like someone who has regretted? No, I said to somebody, I'm not the most religious person in the world, but I do feel at times I was just put on the earth to do this. I never for a second regretted my career choice. And again, for all the amazing experience I've had, and I've had an amazing career, I'm so gratified, and I love the leadership part of it. But at its very root, is, again, it just comes back to those things that motivated me at the very start, the idea that I could be somebody's doctor and take care of them. So those experiences are so priceless. And so, look inside yourself. If you're that person who says, I just want that, I want to have that kind of trust and relationship with patients, then give serious thought to doing primary care, because the level of gratification is amazing. I get so kind of frustrated a bit with people who, have relatives who are physicians, and the relative says, "Oh, don't go into medicine. It's not what it used to be." And I hear that all the time. And I get it. There's a lot wrong with the, how we pay for healthcare, how we provide it. But it never for once occurred to me that I would have not had this experience. I mean, it's just incredible. So no regrets, none, zero.
Glad to hear. What was the most interesting case you've ever had the chance to manage as a family medicine doctor?
Oh my God. Oh, that's easy. I know the answer. And it's amazing that I know the answer, because after a while, how do you pick out one case? But I do remember it. 1981, I think, the end of 1981. Anybody know what the case was? End of 1981? Know your medical history? Put in the chat. That's it. Thank you. Was that you, Christine? Somebody. It was AIDS. But of course, we didn't know it was AIDS. It was an 18-year-old young man, still remember his name, who came to my office. And he was real sick, and I did outpatient blood cultures, which you're kind of not supposed to do. But I said, we'll do a blood culture, and I let him go home. And it grew a really bizarre bacteria that we never see in blood called Bacteroides fragilis. And I called him up and go, "Get back into the emergency room. You have this deadly bacteria in your blood." And at that point, it was the very first AIDS case ever at Thomas Jefferson University. And the articles we were originally called GRID, Gay-Related Immune Deficiency, had not been published yet in the New England Journal. Nobody knew what this was. So we admitted this guy. And I remember when we saw the first article about pneumocystis pneumonia, and I remember so I said, well, maybe you have pneumocystis. And about 3 months later, never got out of the hospital. He died of pneumocystis pneumonia. So, and I remember how frustrated I was, just that we could not, nothing we did made him better. We would treat one disease and something else would come out. So that would have to win. And I'll tell you a family doc story. probably 25, 30 years later, I was the hospital attending. I'm going to make up his name. This is not his real name. And I rounding on a woman in the hospital, and she sees my name, and she goes, "Oh, I never met her." She goes, "Dr. Wender." I go, "Yeah." She goes, "I think you took care of my brother." I said, "Who was your brother?" She says, "John Dalton," not his name. And this was the sister of that young man who never made it out of the hospital. I'd say that was probably a most amazing case. Are we out of time?
Very interesting. Is there anything you wanted to say? There's still a lot more questions. Is there anything in particular you wanted to speak about?
I either could speak or we could do a song. Which one would you rather do?
I think we answered a lot of questions, so you can go ahead.
Should we do a song? Because let me tell you about the songs. So it's not, I do it as, I've been doing songs particularly during my American Cancer Society years, but even going before that. I write these lyrics, and we do them at events, where I speak all over the country, and I chair an organization called the National Colorectal Cancer Roundtable. So we've done a lot of colon cancer screening songs. That's one of my real specialties. But kind of signature. It's been fun and a nice way to end for me for the evening. I haven't had a chance to sing a song in a while, so with your forbearance, hang on. I have too many screens open. That's not it. Let me find this. Here we go. You can't see my screen, you just see me, right? Is that true?
I just see you.
Yeah, so that's right. You won't be able to see the lyrics, but that's okay. You'll be able to hear. We share a health equity dream. We want everyone that we know to join in the efforts we all lead, not accept all the old status quo, to right all unrightable wrongs, find food for all people in need, to work all together as one world, to build healthy communities. This is our quest to reach for our goals. We all know that it's hard. We all know our roles, to fight for what's right without question or pause, to be willing to listen to all and to work for our cause. And I know if we all can stay true to this critical quest, that we'll see all disparities fall, and then still we won't rest. And our world will be better for this. End despair and reduce poverty. To join with our neighbors and colleagues to help build healthy communities. hope you could hear it.
That was the first year.
Yeah,
We had a song that was really unique. I loved it. So good.
We did that song. We had a grant from the Robert Wood Johnson Foundation that funded 12 communities around the country to kind of do health equity work. So
I think a lot of people loved it.
we did that. We did that at our opening event. So
yeah.
Well, I guess we're kind of at the end.
Yeah, thank you so much. That was really unique. It looks like everyone loves it.
It was great. So it was good luck to you all. You're welcome to email me personally if you ever want to. Perfectly fine. Richard.Wender.
I can send out the email later.
Yeah, send out the email. So happy to be helpful with you or hook you up with any fans that I can. So okay.
Thank you so much, Dr. Wender.
Good night, everyone.
Okay.